Thank you for joining us for this episode of the OI Show. Today we're joined by Natalie Chai. We're going to be speaking about clinical signs that lead to radiofrequency, IPL, thermal pulsation, or PRP on the OI Show. Well, thank you again for joining us for this episode of the OI Show. We're excited to be joined by Natalie Chai. Natalie, thank you for joining us for this episode.
Thank you for having me. Such an honor.
Yeah, well, the honor is all mine, Natalie. I've been following Natalie on social media, and seen some things that she's been doing. She is just crushing it in her practice. She practices in Canada, and there's things that she's doing in Canada we are not yet doing in the United States, and it's just super impressive to see some of the things that are happening in your practice. Why don't you start off by sharing with us a little bit about yourself, where you practice, and the practice itself?
Yeah, absolutely. I graduated from Pacific, so Pacific alumni, just like yourself here.
Mm-hmm.
And yeah, just in a blink of an eye, already 7 years has gone by, and it's like so quick.
So fast.
Yeah. Long story short, how my practice opened up was actually I made the decision 1 month prior to COVID when we did those lockdowns. So it was a really scary time because as you know, purchased all the fancy equipment in in February, I should say. And I remember it clearly, March, they were saying everyone shut down, right? They said 2 weeks initially. So I'm like, no problem, got to get things figured out. But 2 weeks turned to 3 months, right? So I mean, it's a blessing disguise. Looking, hindsight is 2020, right? Is that was necessary. That 3 month kind of hiatus was necessary for me to hone in on my systems. That was the biggest thing, and learn a little bit more around that social media aspect as well. And so, thankfully, I didn't do it, all on my own. I have partners, but what I did start cold was, of course, the specialty aspect of the practice. So I call it the trifecta, the dry eye clinic. There, I also do myopia management, and third from there is specialty contact lenses as well. So
Mm.
they all kind of run together. It's amazing, and all what I love about it too, it's long term. So basically, you garner these relationships with your patients, not every 2 years. It's ongoing for life. They don't know it, but when I say life, I mean life, right? So
Mhm.
they'll know that they'll be with me for the rest of their life, as long as, of course, I serve and I continue to deliver as well. So here I
Right.
am. Yeah.
Yeah.
Mhm.
That I love that, and as you know, and many of our listeners know, those are the same specialties that really excite me. I have the myopia podcast, and then we have a dry eye practice, and then obviously with our scleral lens, especially contact lens practice. So it's fun to follow other people who are crushing it and get to watch and learn from each other. And there's always so much that we can learn in just talking with each other. Let's dig into your dry eye practice a little bit. So this opening of this kind of specialty within that, what
Mhm.
was happening before? And then what did you invest in, and what did you change about your practice right as COVID was happening?
Yeah, absolutely. And I think the story is similar as a lot of optometrists when it comes to dry eye management treatment for their patients at the beginning, where, the mainstay and all we had access to, was eye drops, warm compresses, lid scrubs, and such, right? And it was fantastic. But I think you also know too, especially for the moderate to severe dry eye patients and complex cases, those are essentially ineffective, right? It's just a band-aid to get them
Yeah.
from day. And so I was just getting quite frustrated because that was like my cap in terms of what I could do. And then, of course, the other thing too was, doxycycline, right, or antibiotics were fantastic for the acute cases here and there for flare-ups. But
Hmm.
then, it was causing gut issues. I'm like, I can't live with myself knowing that I might be causing ulcers for the patient down the road, right? And so I kind of, I've heard a little bit here and there with conferences about, the advanced treatments with IPL and such. And so I dug deep. I went, conferences prior to COVID and learned a little bit more, chatted with actually Dr. Perryman, through Instagram, and she gave me graciously her time because she's a busy woman, right? Um, reached out to, companies, that distributed these instruments, right? Learned a little bit more about it. Lots of reading, evidence-based is important as well, just to figure out what type of instruments to get, because there's so many out there right now, especially
There
now.
is.
Yeah, so it's like, it can be confusing as to,
Mm-hmm.
what to purchase. So, you know, for me during COVID, I know I had to like dig deep and reflect, especially during that time. Is like, do I, go halfway, in terms of purchasing equipment and my systems, or is it all in? So I did go all in. So it's like, that's all or none for me. And so I
Yeah.
actually did just like literally everything that you can think of when it comes to diagnostics, as well as treatment. So diagnostics, basically whatever you can think of, the tear lab I have, the Oculus, 5M keratograph, Inflammadry, right? Incisional dyes, slit lamp with a, anterior side camera, basically everything they can think of just to help build that profile. And as you know, too, DryEye is very visual for the patient. And so
Mm-hmm.
when they see their eyes, like that's your eye, right? It's just the impact is so much more. I
Yeah.
used to just pull like images on Google and be like, that's kind of what you have. And even then it was actually just as impactful, but when it's their eye, it's amazing. And the buy-in, right? Buy-in, especially as you know, it's an investment when they are considering to purchase, a treatment bundle or such, right?
Yeah.
Issues during COVID with cash flow and such, the buy-in in terms of having them invest in their eye health. It's amazing how many people, will choose to invest their dollars in, something else in their eyes. But, it bubbles into a certain point where their eyes start really bothering in them, then they'll think about their eyes, right?
Yeah.
So,
Yeah.
yeah.
So let me dig a little bit in. So you also bought some treatment technologies, right? So that was your diagnostics. What did you do from a treatment perspective for purchases?
Yeah, absolutely. My first purchase was the IPL, the
Yeah.
Luminous M22. Shortly after that, then the radio frequency came along.
Mm-hmm.
So I have the ND-Med Cure 2.0, and I do have the iLux as well. And then I also have the in-office deep cleaning Zocu kit, from Dr. Peter Pham, and I also do have the Bluff X as well, in office. And then, from time to time for the severe patient, I've actually had a few instances of using the BioD Optics amniotic membrane as well
Mm-hmm.
for that. And then of course there's, autologous serum and PRP drops. We were able to do that here. And I'm working with, actually, I think she's a classmate of yours, Dr. Manya Madan, right? So
It's
she's doing great
awesome.
too, right, with her PRP. So I'm just waiting for her stuff to get in terms of PRP, so we can source it, in clinic versus, outsourcing it to pharmacy, since we're doing it anyways, right? So.
Yeah. So let's just talk about PRP for a moment, because that's not something that we're doing much of in the United States.
Hmm.
What is PRP?
Yeah, so plasma rich platelets. And so
Mm-hmm.
it's there's always a confusion between, autologous serum and PRP, because
Yeah.
essentially principally they're the same, right? However, what's different between the two, of course, are the platelets. So autologous serum, they actually strip it from the platelets, strip out the platelets. So what makes sense to me with PRP is that these platelets have a lot of the growth factors in there. It also, it has a lot of the healing factors that's necessary for recovery. That's why, for me, I don't know about you, maybe you can share too with your experience with autologous serum. It was hit or miss sometimes, right? With autologous serum, at least in my experience. And
Yeah.
so I decided to, reach out to Dr. Madan and it's like, what's this PRP thing too? Kind of similar to you as well. And she swears by it. She's been doing this, I think, for the last 5, 6, 7 years. So she's got a lot of experience with it. And uh, I found that with PRPs is that it has a lot more, healing properties and a lot quicker results is what I've been finding a lot of the times. The
Mm-hmm.
downside is that there is a little bit more inflammatory inflammation because of the platelets there. So you sometimes do need to couple it with, say, like a steroid drop, like a Lotemax gel, just to decrease kind of the inflammation that can sometimes come on with PRP drops as well.
Mm-hmm.
So
So,
and
yeah, I mean, obviously, you've got a lot of things at your disposal. So, I want to get a little granular here. So, you go through all this diagnostics. You've done inflammatory, you do, all of your keratograph testing, you do your vital dyes, and so forth. What is it that you see in a patient's eye that drives you towards IPL or RF? So
right.
those two treatments, are something that is continuing to gain in popularity. And a lot of practitioners are like, I don't know. And I don't know if that's going to be something. Is it just the cosmetics? Because so many people are like, oh yeah, I'll bring that in and get people to look really good. Or is there something diagnostically that you say, oh, I see this, that, and the other thing that points me towards doing this particular type of treatment, IPL or RF?
Yeah, definitely. And so this is exactly the way that I would explain it to a patient, is that with IPL, as you know, what it targets, where it shines is inflammation, right? The chronic inflammation portion of dry eye. So then what we look for then, of course, is the ocular rosacea. So the telangiectatic vessels along the lid margins. The key word, of course, is you got to look for it. But I mean, a lot of times, a lot of dry eye patients will already have it along their lid margins. And so that's number one thing. And of course, with the inflammatory, it does confirm those inflammatory markers on the ocular surface. And so that's certainly for sure number one. The ocular rosacea automatically in my mind will be the IPL. The other thing too, on that same note, dovetailing from that, is that because we know, inflammation is the driving force of chronic dry eye. Even if I'm not seeing too much, telangiectatic vessels or whatnot, I still consider IPL because, like an angry person, if your eyes are constantly, chronically, angry, for instance, whatever you do on top, it's not going to be effective. So it's like an angry person, got to calm them down, got to calm the eyes down first with, say, IPL. Therefore, what you do, at home, for example, will have a better fighting chance to work. So I always explain it that way. Now with RF, of course, meibomian gland dysfunction or meibomian gland atrophy or blockage, right? Actually learned it from you, right? With the meibomian gland evaluator, like the amount of like MGYLS, or I can't remember what it was, but that's actually where
Meibomian glands yielding liquid
building. There we go.
secretions.
Yeah,
Yep,
exactly,
YGLS. Yep.
exactly. And so that's exactly what I actually use is the per position of no gland expression with the evaluator here. I would think about radio frequency, and so I have found because radio frequency is still pretty much in their baby stages still, right? In terms of the efficacy clinic wise. I do find that it does provide fantastic expressions superior to that of, say, when I do iLux. I do have to say that. And I think it's because of the type of energy being used. Because iLux, LipiFlow, and like a warm compress, and how I view it is conductive, right? We're trying to move heat from like the activator or like the warm compress to the skin and through the skin to where the meibomian glands are, which is pretty deep, right? In
Yeah.
the layers, right? It's even past the dermis. So with the radio frequency, as you know, it in my handpiece, there's no heat. It's electromagnetic radiation, right? And so the electromagnetic radiation then is absorbed to your skin, which is absorbed by the water chromophores in your skin, and that causes movement. Movement causes friction. Friction causes heat. So actually, the heat is coming from the person's own body. So this is what I call inside out heating versus outside in heating, right? We're not pushing heat through, it's coming from the inside out. And so I think this is where it's important when it comes to, expressing, is that, as you know, for liquefying or melting the oils in the oil glands here, it requires 42 degrees Celsius,
Right.
centigrade.
Yep.
And so with a warm compress, the surface of the skin gets way too hot for it even to penetrate through. And so the radio frequency, we get there because we're getting the oils to heat up to 42, and then it rises to the skin, to the surface. And so like the expressions, and I've posted it, I've been pretty bad lately in terms of posting, but I have posted a few things in terms of expressions, and they're amazing in terms of what comes out. And which brings me to the point in terms of which do I choose? A lot of the questions that I have is, well, which one's better, IPL or radio frequency? And I feel that might not be a fair question to ask because it's apples and oranges.
Mm-hmm.
Even though, IPL does have a heat component, but, IPL, I think of it as, inflammation, targeting that, and then radio frequency is for the blockage. So what I have been doing for my patients is actually 98%, and that's a true stat because I had to look at it. 98% of my patients, at least in my experience, have combination IPL and radio frequency to complement each other.
And how do you do that clinically? Do you do them both on the same day?
Right, yeah. And so my model right now is I do radio frequency first and together with the in-office expressions. And then 2 weeks after that is the first IPL. And then 2 weeks after that, so I alternate. So I do a total of 8 treatments, 4 of each alternated. So there's a bit of a time commitment for the patient up front, but they understand. So we set up the expectation for them is that, yeah, you kind of have to make your appointments, right, for this to be effective, right? And so that's kind of how my model has been. And so far, knock on wood, it's been very effective for the most part.
And you published a study on 34 patients, I think it was, that you did in this. And it was, I mean, you got some pretty good results utilizing this process of every 2 weeks. What a commitment on your part and the patient's part. That's a lot of work. Why can't you do them both at the same time?
Right. I mean, technically you can. And so, but the thing for us, it's a long appointment, right, for the patient. Like the radio frequency already takes about 20, 25 minutes or so, and then add on, say, 10, 15 minutes for the in-office expressions, right? And, I videotape, the expressions for my patients. So a lot of the chair time is just me showing them like what's coming out. So, and they're amazed by that, which is great. And then, of course, the IPL, even though it's quick. So what I've actually added this year is I've actually started to do more of the facial rosacea treatments too. And so it does take a little bit more time. It used to take, say, 10 minutes, but now because I'm incorporating the protocols for facial rosacea treatments here, it does take closer to that 15 to 20 mark. So if you can think about it, it can be, like an hour, an hour or so. And a lot of times after the radio frequency treatment, patients' eyes are really sore just because I'm using, forceps, the expressors, and they're done basically after that session.
Do you express after IPL?
I don't at this point, but I do lid debridement after IPL. So I kind of again go
after you do lid debridement, not before. Why not before?
Oh, yeah. And so not before. I feel that the heat component from the IPL loosens up those dead skin cells against the lid margin and the line of marks. So I found that it was actually a lot easier for me to scrape it off after the IPL while the skin is still relatively warm. A lot more comfortable also for the patient too. So I'm not like right there trying to scrape everything off, over and over. It does come off a lot nicer. In my opinion.
Especially with that ultrasound gel on there, right? Get a little bit of that mixed in, and Wow, so we have to ask this question because you've mentioned it. Is you also have an iLux? So when would you choose iLux over one of these other things clinically? There may be a patient who chooses one or might be more comfortable with one, but if you're looking at the patient, when are you going to say RF versus iLux?
Yeah, absolutely. And so I have iLux positioned now for the asymptomatic, but we see it clinically changes, and also the mild dry eye patient, whether it's the patient's using drops here and there, for instance, or if I find because with the routine exams we do screening, real quick screening on the lower lid meibomian glands, so I can tell right away whether or not they're on their way to symptomatic significance of dry eye. So I show them that and I say, well, if you want to be ahead of the game and not having spiral down, having issues with your dry eye, we can do an eye lux. It's one time because of course it's one treatment. So they don't have to commit to say like the bundle of treatments per se. It's a lot cheaper as well.
Mm-hmm.
And so a lot of times I think most people, especially during COVID now, a lot of people are a little bit more health conscious about being preventative. And so I feel that with iLux, it's positioned fantastic that way. A lot of people are already doing a warm compress, but have fallen off that bandwagon. So I say, well, here is an opportunity for us to do it for you in office. iLux, a little more effective. And also it does have that massage as well.
Yeah, I don't want to know the specific numbers because I certainly don't think you should share them. But if somebody did an iLux versus did a radio frequency, you said it's a lot cheaper. Can you give us an idea of like a percentage that it would be difference?
Yeah, so close to about 60% cheaper.
Yeah,
around there.
yeah. And that's for one iLux treatment versus doing 4 radio frequencies. I presume you have a package for radio frequencies, a package for IPL, a package for IPL and radio frequency combined because of this process you have. So that's a pretty substantial difference for those people who are not ready to make that commitment and so forth. What have you seen change as far as the pharmaceuticals or the other recommendations that you've given since bringing in radio frequency and IPL?
Yeah, absolutely. Number one, I've noticed off the bat is a lot of patients that are referred over to my side because I'm thankful and grateful that a lot of my patients that I see is in-house since I have partners. So that has certainly helped my growth over the last handful of years. But the number one thing that I've noticed is a lot of these patients are on, whether it's their optometrist or themselves over the last handful of years, have been on like say Lotemax or prednisone long term because of battling say like the inflammation, red eyes, all that stuff. So they've been on it for like say for years. So since doing IPL and radio frequency or whatever it is, and what any of the advanced treatments, they're off of it entirely. So they don't have to reach for their Lotemax gel anymore. They don't have to reach for Allrex, right? That's another popular one that we're seeing by eye individuals. The other thing too is a lot of individuals also have been on Doxy for whatever reason. Again, for inflammation, they're off of that too, which is amazing. So a lot of these, drugs that were used, which are fantastic, they work, right? That's why people use them, but it's, the side effects coming off of it long term is just not good. So this is where the advanced treatments is, a drug-free, drop-free, minor surgery-free option, more effective. Yeah.
That's phenomenal. Well, thank you for sharing with us your experience here in this explosive dry eye practice that you've had in the last couple of years. Obviously, some really, really great things. I think, my takeaway is how we can clinically target the specific things with these different treatments. I think a lot of practitioners come into it and say, oh, this is for all dry eye patients. But in the reality, there's still differences between these different mechanisms. LipiFlow has a difference from an iLux, and iLux has a difference than radio frequency, and radio frequency is different than IPL. And when do we use them? Because there's so many things that are out there. How do we look at inflammatory and telangiectasia? How do we position things when we see redness of the eyes? And so I appreciate the fact that you really clinically boiled down where to position these sort of things. Thank you. That's awesome.
No problem. Thank you.
Yes. And thank you for joining us for this episode of the OI Show. Make sure to like and subscribe and stay tuned for future episodes with amazing guests like Dr. Natalie Chan. Have a good one.